morning. Thanks so much for joining us today for our webinar on abnormal fit follow-up and surveillance. We had a great crowd register for today, so I think a few will be logging in over the next few minutes. My name is Sarah Ashton. I am the Regional Manager for the Central East Regional Cancer Program and the Indigenous Cancer Program. Again, want to say thank you for joining us today for this talk hosted by Dr. Hugh Kendall. I'll take care of a couple of housekeeping items and then I'll introduce Dr. Kendall and we'll get started on the presentation. For any questions, we're going to use the Q&A feature at the top of your screen. We'll be monitoring for questions. If there's some clarification needed about the content that's on the slides, we'll pause and we'll address those questions. We definitely have time at the end for some broader discussion and questions. So some of the questions we may save till the end where we have a bit more time to go into detail. But anything we're not able to answer today, we will follow up with a summary of responses to make sure that the questions do get addressed. So without further ado, I'd like to introduce Dr. Hugh Kendall. Dr. Kendall is the Regional Colorectal Screening and GI Endoscopy Lead for the Central East Regional Cancer Program. Dr. Kendall has been involved in endoscopy and quality management of endoscopy through the College of Physicians and Surgeons of Ontario and Ontario Health CCO for the last 15 years. There's many accomplishments and a lot of experience that Dr. Kendall brings with this role. So we'd like to thank him for his leadership, and I'll hand it over to you, Dr. Kendall.
Thanks very much. We can go to the next slide.
Yes.
Who are we going to be?
I think that's me. So
yes,
thanks so much. I would like to introduce myself. I'm Shannon Burke. I'm the Director of Regional Programs at Lakeridge, which includes the Central East Regional Cancer Program, the Department of Family Community Medicine, and the Indigenous Cancer Program. So it's an honor to be here today with everybody, and we'd like to start the day off in a good way with a land acknowledgement. So I'd like to respectfully acknowledge that I live and work on the lands of the traditional territory of the Mississaugas of Scugog Island First Nation. The Central East region, which is from Scarborough to Northumberland, all the way up to Haliburton, is located on Treaty 20 of the Mississauga territories, collectively known as the Williams Treaties First Nations, which include Curve Lake, Hiawatha, Alderville, Scugog Island, Rama, Busale, and Georgina Island First Nations. I'm grateful to the Indigenous people for their care and teachings about the land and all living things, and I commit to continue to actively engage with local Indigenous communities to build meaningful relationships and learn more about their resilience and amazing people. As a second-generation Canadian, I acknowledge that I have much to learn about the rich history, culture, and contributions of Indigenous peoples. As I send my 3 children off to school each day, I reflect on and acknowledge my incredible privilege in being able to choose which school they attend and send them off with relative certainty that they will come home safely to me each night, a basic human right that was taken away from Indigenous families with the implementation of the residential school system. In the spirit of reconciliation, I recognize the importance of turning this acknowledgement of my privilege into action. In my role, I've had the honor of being able to learn from many Indigenous elders and knowledge keepers, and I'm so appreciative of their teachings and guidance. My personal commitment to reconciliation is to work towards a health system that not only reflects health equity, but also honors and celebrates Indigenous cultures and all cultures of the many wonderful teachings we can learn from each other. And while Canada may have a dark history, certainly in terms of Indigenous peoples and the treatment of Indigenous peoples, the team that I work with every day makes me hopeful and optimistic for a bright future. The Indigenous Cancer Program is doing some really, really great things in terms of increasing knowledge and awareness about the history and hardships that Indigenous peoples have suffered. And I'm really optimistic about the brighter future we can all have together through that increased awareness. So thanks so much for the opportunity to make that acknowledgement today.
You're just on.
Sorry. So the next series of slides really go through who I am and whether or not I've been paid or what conflicts of interest. I am the regional lead for colorectal cancer screening for the Central East region. I've had that position for probably between 12 and 15 years. I'm not quite sure. And as such, I receive a stipend for doing this type of work, but I don't receive any other stipends. I'm not a member of any boards, or I don't receive any money for reviewing or advising on products of any kind. Next. Next slide. The commercial support received is from Ontario Health through my role as regional lead, and there's no other financial backing for this particular presentation. Next. And this program uses evidence-based content developed by Ontario Health. Next. So. I am mindful of everybody's early morning and their time. And while this is an accredited activity, it also can be it can be to the point, it can be useful, and you can leave today with a few more insights about FIT and how it can be more effectively and easily deployed through your office. So today's agenda is going to be, I know everybody on this call has been using this program for 6 years, and I'm not wanting to go through the basics of, how new it is and what challenges it poses. We kind of all know that. What I'd like to do is to go over a couple of basics that sort of need to be reinforced, and then we'll talk about, when there is an abnormal FIT, how to efficiently and properly target the referral. So next, and next. So we're going to spend some time on this slide. And those who've worked with me know that I just hate reading PowerPoint slides that are densely populated with information. I much prefer to sort of talk and take questions either at the end or through. And so this has very little information on it, which is a perfect time for me to talk for about 5 minutes. The basis of the FIT kit is a stratification of risk between average and elevated risk. It's that simple. And the real questions and difficulties sometimes come from what is average risk and what is not. And there's justifiable confusion because in the last 15 or 20 years, there have been a series of guidelines that have been accepted by the practicing community, and those guidelines have changed. If we go back 15 years ago, a definition of family history was not just a first-degree relative, and by that I mean someone with whom your patient shares 50% of their DNA, so it's a parent or sibling. The second degree is people with whom they share 25% of their DNA, aunts, uncles, grandparents, and then we get into great-grandparents, cousins, and things like that with whom they share 12.5% of their DNA, and we really never cared about that third degree of people. And part of the reason for that was your cousin may have had a colon cancer at the age of 20, and it may be very much on everybody's mind in the family, but A, your patient has a 1 in 8 chance of having that gene, and B, that gene went to your patient through a series of other individuals. And if we don't see colon cancer in those other individuals, then that's not probably a very powerful or expressive gene. So, and once you get out to that third degree relative, for sure, the story of I'm a healthy 50-year-old normal person is a much more scary story from a colon cancer point of view than my cousin had colon cancer at the age of 26. Now, older set of guidelines used to count 2 second-degree relatives as equivalent to a first-degree relative. Those are the guidelines from CAGS in about 2008, 2010. And the guidelines there would be that if you had an aunt and a grandparent, you'd start at age 40, but you'd go every 10 years. The game changed, obviously, when we started using the FIT test in 2019. And I'll just expand a little bit about it. The FIT test is not anything like the old FOBT test. Sorry, is there some audio going? So the old FOBT test was a test that used a color change reaction to detect any hemoglobin at all. And part of the problem with that was that it would detect upper GI hemoglobin as well. If your patient flossed their teeth and swallowed it, they had a nosebleed and swallowed it. There were a lot of false positives. It was a pretty good test in that those kits used to be very heat stable, very cold stable. They had a half-life of about 3 or 4 years, and they cost about 32 cents a piece. The fit test has reagents which will stale date in several months. The kit costs about $7 a kit. We mail out about 10,000 a month, so it's an expensive program. But the beauty of this test is it uses antibodies to human hemoglobin, which practically means that any blood that has seen digestion in the upper GI tract will not show up. So, if it's seen stomach acid or amylase from the pancreas or anything else, it will twist the protein of the hemoglobin and it will not bind with the antibodies. So the beauty of the FIT test is it's about 6 times more sensitive than the FOBT, and you're only going to be looking from the lower GI. So it's a very, very good test. It has been deployed in Europe for decades. It's been deployed in Canada, in Newfoundland and Alberta for probably 15 years. And Ontario's fairly late to the party, having deployed it in 2019. There's a very good test, study, which we can include in the notes that follow this presentation. It's for the reference, the study is Quintero, Quintero, from 2012. It's a study with 35,000 people doing a FIT test, and another 35,000 people randomized to doing a colonoscopy. And then you let people choose if they want to switch groups, they can. And then you follow people out and see which group has higher rates of colon cancer and colon cancer death. And for average risk people, it is exactly 100% identical. Moreover, more people choose to switch from colonoscopy to the FIT test than choose FIT to colonoscopy. So the advantage of this test is you're going to engage more people. It is absolutely, totally 100% equivalent in terms of decreasing colon cancer mortality. And it's a very cost-effective way of increasing participation in colon cancer screening. So that's the rationale for why we've chosen this test. Let me address one of the big issues, which is, but it doesn't find any polyps, or it doesn't remove any polyps. And that's true, the FIT test doesn't. But the number of people who die of polyps is, and always will be, 0. Nobody dies of polyps, people only die of colon cancer. And here's how the FIT is effective. If you think of it kind of on a molecular level, most polyps will sit there and grow and do nothing. Tubular adenomas, low-risk polyps, year after year after year, they will grow very slowly, and they will become slightly larger versions of their otherwise uninteresting self. The very, very rare polyp will begin to grow and change as it grows, because the cells that are being made from the previous versions of the cells. So you're like making your photocopy from a previous photocopy, and with every generation of photocopy, that piece of paper gets blurrier and darker and harder to read and less like the original. And as they grow faster or slower, the copies will become weirder and weirder. And at a certain point, cells will get weird enough that they lose the ability to make a decent copy, and then the weirdness goes up exponentially. And that's kind of the road that leads to a cancer. And most polyps won't ever go down that road. It's probably 2 in 1,000 that will. Polyps that are going down the road to becoming a cancer will have an accelerated rate of growth, which means that at a certain point, they will start to grow and add cells to their outer layers faster than their own blood supply. So a dangerous polyp is one that will accelerate its rate of growth, and at some point it will be growing faster than its own blood supply, which means that the outer surface of that polyp will be shedding cells that, like, they can make the cells, they just can't keep them alive. And the outer surface of that polyp will be kind of scabby all the time, and it will reliably shed red blood cells every single day of the week at an increasing rate. So we over-designed this test to detect a ridiculously small amount of blood. Sorry, somebody's mic is on. We over-designed this test to detect a ridiculously small amount of blood. Like 1 drop would turn 100 people's tests positive. And when we don't find that blood, we can say with some confidence that there's no real likelihood that they could possibly have a dangerous polyp. So that's kind of the rationale for FIT. That's why it's so much better than FOBT. And it has been a default go-to primary screening test in Europe and other parts of Canada for much longer than Ontario's had it. So it's not a new cost-saving measure. It's a tried and true equivalent means of detecting colon cancer in its early stages. So we can go to the next slide. We'll see in 2 slides from now, with what it can be very confusing as a primary care provider or even an endoscopist to discern exactly who should be having which test sometimes. But in essence, first of all, the FIT test should not be used in the way that the old FOBT did, which was my patient came in and told me they thought they might have seen some blood. I wonder if you should have a FIT test. It's not to be used in asymptomatic patients. There is, I believe, still an FOBT, which is non-colon cancer check program that can be done through your regular blood recs. But the FIT test is to be used as a screening test only, and not for symptomatic patients. If they have a first-degree relative, like a parent or sibling, mother, father, sister, brother, they're never going to be a FIT person, ever. They don't get it. They get colonoscopies. All of the other groups that are listed in the slides that are coming up can be summarized as the people that you should be using FIT are in the people who don't have an appointment for colonoscopy in the near future. That includes people who have polyps and need a follow-up. It includes people who get colonoscopies on a regular basis because of IBD. It includes people who are known to have familial polyposis syndromes and have if they have an appointment for colonoscopy in the future, they should have their colonoscopy. They don't need FIT. Next slide. Is there. So I've tried to summarize this. We use FIT in people 50 to 74 who have no parent or sibling and they have not had a colonoscopy in the last 10 years. I'll get to that in a second because that's another issue is, okay, after colonoscopy, you shouldn't need a FIT test for 10 years. But I see a lot of patients that are often, they've had a colonoscopy 3 years ago and they're having FIT again. So we can talk about that in a second. We don't use FIT in people who have a first-degree relative. We don't use it in symptomatic patients, and we don't use it in people who have an appointment for upcoming colonoscopy. At the bottom, you'll see FIT maybe, and the FIT test has been validated as a very useful way of knowing whether or not there are quickly growing polyps in the colon for all the reasons that I just expanded upon. And it is reasonable sometimes to extend the screening interval past 75, particularly if you're following up a polyp. If someone is over 75 and their last screening maneuver was normal, then typically we stop screening at that age. But if you're following up on a polyp, that's always very reasonable. And traditionally, the follow-up has always been a colonoscopy. FIT through large databases has been validated as just as effective in following up low-risk adenomas. And that means it's a tubular adenoma only. There's no faster growing component like a villus adenoma. It's a pure tubular adenoma. It's less than 1 centimeter and there's only one polyp. So if you're following up on that kind of situation in someone who's 78 years old, they might very well go for a colonoscopy. But if they, have angina when they blink their eyes and they have a defibrillator and they've been in hospital last month for a congestive failure, well, I probably wouldn't screen any of those people because their survival is probably too short. But let's say they had terrible kidney problems or one lung, you might do a FIT test instead. And that data-wise is completely validated. I would, to be truthful, I would say it doesn't enjoy the confidence of 100% of the endoscopy community. But when we look back 2 or 3 years when this idea was first introduced to the endoscopy community, the acceptance of using FIT as a follow-up for a singleton tubular adenoma in higher risk patients is certainly growing significantly over the last few years. So it remains a decent option. Next slide.
Just have a quick question, maybe
Yep.
for clarification. So some gastroenterologists recommend FIT tests between colonoscopies. Should I, as a family doctor, order this or push back? No.
You should push back and suggest that they look at the guidelines, because that's not even a gray area. That's just not correct. This is the slide that I referred to as being sort of, even for me as an endoscopist, difficult to sort through. And I think part of the goal of this morning is for everyone on the call to have a more simplified idea of who is appropriate for FIT and who's not. It's like if you have a family history and the family history is parents and siblings, then you should not have a FIT. And if you're symptomatic, you should not have a FIT. But otherwise, the vast majority of people who only need the services of colon cancer screening should consider a FIT if they're within the right age group. Next slide. This is another thing that needs to be sort of debunked or discussed at least. It's a very, very prevalent idea, is that somehow FIT testing is inferior to colonoscopy. Its benefits lie in the ease of application and the cost of application, but ultimately, if it were your family member, you'd want them to have a colonoscopy. And even if they're doing the FIT, that at least one colonoscopy in their lifetime to decide if they're polyp formers or not is worthwhile and adds value and decreases colon cancer deaths. And there is no data that supports that standpoint at all. The production of polyps in any patient is not linear. It's not geometric. It is random. And if the idea is that you're going to do one single spot check at some point in their life to decide whether they're polyp formers or not, it doesn't work that way. Some people could have 5 polyps by the time they're 50 and never make them again for the rest of their life. And some people could have no polyps and end up with a colon cancer at 65. So the baseline colonoscopy, or have it once, or okay, FIT's okay, but if you really want to go for the platinum plan, it's colonoscopy. That's, by data, just not true. Next slide. This is a slightly confusing slide because what it's trying to detect is, of all the people that underwent screening, what was the screening test that you did before? And in the vast majority of people who are doing FIT, we're seeing that their previous test was also a FIT. Not surprising, because FIT's been around, it's done every 2 years, and colonoscopy's done every 10. I think what I took from this was that the participation in the FIT program has decreased over the last, since the start of 2024. So, over the last 15 months, there's been a reduction. Now, there's always, in the first few years of this program, there will always be. So in the first 3 years of this program, there will always be a waxing and waning, because obviously everything started in June of 2019. And there's going to be a whole bunch of people who become due again in June of 2021, and June of 2023, and June of 2025. And also, as much as those humps have been smoothed out data-wise, it's also true that that COVID will have changed that somewhat with the pause that happened in 2020. But I think it's interesting that the overall participation per quarter has decreased, and that may reflect the changes in incentives for primary care physicians. Next slide. So what I mean to discuss here is that certainly patients can be sent for colonoscopy who are average risk. The idea of the FIT test is that it's equivalent with colonoscopy, and that patients should be offered both. Ontario Health does prefer that average risk people get a FIT test and not a colonoscopy. And but when we say that they are completely equal in this risk group, what it means is that everybody who chooses between them will choose on the basis of something other than how good the test is. They'll choose colonoscopy or FIT based on which degree of what level of closure it gives them, sometimes by how much family pressure they're getting because, you know, Aunt so-and-so was recently diagnosed with a colon cancer. But there are a number of reasons. What's maybe not intuitive is that there are consequences to your local endoscopy facilities and the system in general for higher than average risk colonoscopy screenings. So when we do colonoscopies at the hospital, if anybody has perused the fee schedule, a colonoscopy starts with a Z code, and there are about 7 Z codes that describe why you're doing it. Z555 is average risk screening colonoscopy. Nothing's wrong, just colon cancer screening. 496 is for symptoms, 498 is for polyps, 499 is family history. It goes on. But the Ontario Health measures which codes are entered at every colonoscopy. That's part of the data portal. And as endoscopists, for every case that we do, we submit about 26 data points, including when the referral is received, when the colonoscopy is done, why it's being done, how many polyps, do you think it's a cancer, was there a biopsy, all of that stuff. But what's measured, and one of them is why it's being done. And Z555 as average risk screening colonoscopy, if that's how it's coded by the hospital, that goes in the database. The long and short of it is that there's a quality metric that this number is less than 5%. And I will say that one of the hospitals in our region, a large hospital, last year had been having an issue with up to 25% of the colonoscopies that were going on in their facility were being coded as average risk. And after about 2 years of warnings from Ontario Health, last year in 2024, and by the way, I should sidebar and say, not all of those 25% were actually average risk. It was a data reporting error in Epic, but that's a sidebar. But the point was that at the start of last year, this large facility was told, you have a 25% average risk colonoscopy rate. We want it to be 5. 20% of your colonoscopy budget for the next year will be removed or chopped. So this large facility had 20% of its yearly endoscopy budget not given by Ontario Health. And it was only through the efforts of multiple people that ultimately the funding to complete the year of endoscopy was given. The point is, there's room for the occasional people. We are offering both for screening, but sending your average risk patients as a routine for average risk endoscopy means that your local endoscopy facility will be penalized and will have less funding and therefore less availability, and therefore the wait lists for endoscopy of all kinds will go up. So there are real consequences to average risk screening with colonoscopy. Next slide. What I wanted to get across with this slide is, what I often tell patients when I'm explaining FIT in the office. Prior to 2019, we had one lane for colon cancer screening. It's colonoscopy every 10 years or different, 5 years or 2 years, depending on what your risk group is. And now we have 2 lanes. We have one lane can be the FIT test every 2 years between 50 and 75. The other lane is colonoscopy. People can certainly switch from lane to lane. If we can go to the next slide. It's certainly possible to choose. Everybody should be in one of these 2 lanes at all times between 50 and 75, but no one needs to be in both lanes at once. When you do a FIT test and it's normal, you're considered up to date for colon cancer screening for 2 full years. You don't need to re-up until 2 years. When you do a colonoscopy that's normal, you don't need to re-up until 10 years. You do not need to do FIT tests in between colonoscopies. The point of the colonoscopy is, it removes all polyps, benign, slow growing, glacially slow growing or not, and you're starting from absolute zero. There are no polyps in you. Statistically speaking, it should be a good long time before anything can possibly grow that would threaten your health. So the point is that after a normal colonoscopy, FIT does not resume for 10 years. Next slide. This is an interesting and possibly shocking graph that shows the number of fit kits that are sent out that are actually ultimately returned. Remember, I said that we send out about 10,000 kits a month. That's $70,000 a month of cost, and roughly 30% of those never get returned. So that's a moderate amount. That's $21,000 a month. That's $250,000 a year or over. Now the dip in the graph should not alarm you. This is a cumulative graph, so we're looking if you look at the second last column from the left, that's October of last year. Some of those kits are going to be coming back this month, next month. So that tail end that you see to the right will come back up. The point though is that a lot of kits that are sent out are not returned, and sometimes this can be due to issues with patient communication in terms of ordering the test or following up on the test. Next slide. There's a lot of support that's available to your office in terms of nudging or cajoling or reminding patients about the kit once it's been sent out. I think it's very difficult to expect a high percentage of patients to return their kits in a timely fashion if they receive them out of the blue without any warning, and it comes in that sort of dun-colored government envelope. And what happens is once the patient realizes it's not a driver's license renewal or a CRA notice, it just kind of goes beside the phone and gets stale dated. I wanted to go quickly into why it is as complex as it is to get the kits. The FOBT kit that we talked about before and that many of you will have used for decades was very heat stable. And as I say, it lasted for 6 years and it was very low cost. So it wouldn't have been a problem for me to have a big pile of those kits beside my desk or even in a pharmacy that patients could just go and pick up. The problem with the Fit Kit is that it has reagents to do an amazing job of finding a ridiculously small amount of hemoglobin, but those reagents will stale date in several months. And so we want to make sure that every patient that gets a kit gets one that's essentially fresh out of the oven with a maximum of its shelf life in it. We also don't want to send a $7 bill out into nowhere. So we need to have a valid address, and the person who's notionally likely to have that address would be the primary care provider. So that's why there's a request that goes through your office to validate the address. It's sent out, and that's also why even when patients are enrolled in the program, they don't automatically get another fit as the way they might with a mammogram. We don't know if the patients have moved in the last 2 years, and again, we don't want to send a $7 bill out into the ether. So this is the reason for the seemingly complex and labor-intensive and admin-intensive way, but it's necessary for this really sophisticated test. Physician link correspondence is something that many of you are able to enroll in. It does send out reminders to your patients through multiple screening programs that have your name on it, and it sort of it helps nudge patient behavior more effectively if it's seemingly linked to you rather than coming from the government. Next slide. We are making a lot of effort to make our program available to as many people as possible. And with the number of unattached patients in the province, it's a huge problem for screening, taking care of this population. So Health 811 does allow patients who are unattached to request a Fit Kit. And if it's positive, there is a code, Q043, that if you belong to an organized family medicine group, if you roster that patient and keep them as a patient, there is a sign-up fee for that Fit positive patient. Next slide. There have been a number of interventions to try and increase the availability of Fit testing since we started. There is the ability from the start for patients who have no insurance whatsoever. The kit is available for $59 from Life Labs. In September 2022, during COVID, when people were unable to easily update their health cards, the ministry made it possible for people with out-of-date OHIP cards to receive FIT kits across the province. And in December of 2023, the 6-month guideline was extended to 12 months. After some data analysis, the reagents remained stable enough to be returned in 6 months. However, what that 6 months means is that once the kit leaves Life Labs, that we've now found that it is heat stable and cold stable for up to 12 months. Once the kit is opened, the half-life very quickly diminishes. So an opened kit needs to be returned to the lab much more quickly. And this is the issue that we're having with the recent mail stoppage, is that an opened kit will stale date typically within 1 month. And when a kit's been deployed and there's a specimen in there, it needs to be received at the lab. Otherwise, there will be breakdown of the chemicals, essentially the antibodies that we want to look for. And that's just a hydrolytic, basically organic chemistry related breakdown that we can't get around because we can't change the laws of chemistry. Next slide. On the horizon is a very exciting project where our region is going to try to partner with an online health service that will allow patients to request a FIT kit on their own. So these are patients that are part of your practice, that are rostered, but if for whatever reason scheduling conflicts make it difficult, they're able to request the kit on their own. And there's a couple of different advantages to it. One is that it saves admin time in your office. Second is that you are notified of their request. The main thing is that in order to get the kit, the patients will register through the website, which will include an email address, and the email address will allow us to nudge the patient for unreturned kits. So automatic email reminders, hey, 3 weeks ago we delivered a kit to your thing. Do you know where it is? Let us know if you can't find it. Otherwise, please send it. And that should really address that 30% unreturned kit rate. Now, in terms of keeping primary care providers in the loop, your offices notionally would be notified when the request is made. Hey, so-and-so has just requested a FIT kit, and your offices would obviously be copied on all of the results exactly as if you'd offered the kit. It's a pilot project. It has not yet been deployed. The timeline is sometime within the next months to a year and a half. Next slide. This one, I'm sure we'll get some questions. There has been talk at the provincial level of offering FIT testing to patients 45 and over. This is an acknowledgement of really two forces in the marketplace, if you will. One is a straight out data-based acknowledgement that the incidence of colon cancer in people before the age of 50 has risen. It was somewhere around 8%. I think it's probably closer to 10, depending on who's measuring it. But there is an acknowledgement that the incidence of colon cancer in younger people is increasing. It's also something that is in the news with revised breast cancer screening guidelines. And so this is certainly on the radar. It will not be deployed in the next 6 to 12 months, but it is likely coming down the pipe. Next slide. Following up an abnormal FIT. So let's just summarize. What I tried to get across with the last section was the idea that FIT is a good test. It is absolutely as good as colonoscopy, and that deciding who gets it and not should not be terribly difficult. Unless you have a parent or sibling with colon cancer, or unless you have an automatically colonoscopy booked through other providers in the next few years, your patients between 50 and 75 should be enrolled in a FIT program. So when the FIT test comes back as positive, I think everybody on the call knows that the guideline here is 8 weeks. Can we have the next slide, please? And the longer that there are delays, the longer that there will be the presence of advanced colorectal cancer. For this, in the right-hand column there, that's defined as stage 2 to 4. So anything other than stage 1 cancer without nodal involvement. Next slide. And so what's not intuitive in the 56 days is, if you unpack that, the 56 days from abnormal result to colonoscopy includes a number of delay-prone stages. It includes all the admin delays through your office. When are you coming in? When are you reviewing your results? When can you get a hold of the patient, to make the referral? Once the referral's made, it includes all of the admin delays in the surgeon's or endoscopist's office. And as endoscopists, they are not in the office every day of the week. They're in the office a couple of days a week because they're obviously doing procedures on the other days. So when do they review their requests for referrals? And then, of course, once the endoscopist has reviewed it and decided to proceed, then there's the hospital-based delays. If you decided right now to book a scope, could you get it done this week? Would it be next week? Would it be the week after? So when you think of all of those admin-related delays, 56 days is and can be a challenging time to get the procedure completed. The key that we're asking this group to focus on is rapid referral out, okay? And rapid referral out isn't just anywhere, it's to the right place. So the Central East Cancer Program, our region alone, has a number of tools to help make that rapid targeted referral easier. Can we go to the next slide? On the Central East Regional Cancer Program, cercp.ca, if you go to the web page, you'll see bottom right, community and healthcare provider resources. And under that, on the colon cancer check program, you will see ocean-based referrals for Scarborough and for Lakeridge. So you can make a referral through Ocean. And if you're not, and I would say Scarborough has been sort of leading the way in terms of centralized referral for FIT positive patients. Other facilities in the region have been taking note of the successes of Scarborough, who were the first to do it. And there is talk about a regional central referral system coming. We've had preliminary meetings to talk about that. It would likely be on a program like Ocean. But let's say you're not going to use the Ocean system, or you're not in the EMR. Next slide, please. We also make available on the website a list of every endoscopist in the Central East region. So you can know at which hospital, how many endoscopists work there. You can also, there's a hospital list and an OHP list. So you know whether someone works in an OHP or whether they work in a hospital. And this is kind of relevant. Next slide. This is kind of a sidebar. This goes back to looking at your screening rates, and it is available to you through your primary care integrated report. You should be able to go up and look online and see, whether or not you are screening an appropriate amount of your target population. Can we go to the next slide? So I want to, Sarah, can you just tell me, do we have the criteria for referral on the slides, OHP referrals? I thought we did. I'll talk about it, and if it comes up in a different slide, we'll do it.
It's in a
Can
few
we go back
slides
to
from here.
the OHP and hospital list, please? I'll just go ahead and say, I said that rapid referral out is key. It's targeted rapid referral out that's key. And we know from having done a deep dive with different facilities that sometimes, oh, that's good, perfect. That's the slide I was talking about. We know from having done a deep dive on various facilities and within the region that there can be delays that are built in when patients are referred to OHPs. And this is nothing against OHPs, because I owned and ran an OHP for 17 years. So some OHPs will have essentially a fax input line, and your patient will get an appointment, very, very rapidly. What those OHPs, they often have staff who have a footprint both in the OHP and the hospital, which is great, but there will be an input delay while the referral is reviewed by the endoscopist, and it's essentially the job of the endoscopist to recognize that this patient should not receive deep sedation outside of a hospital. And for sicker patients, or more precarious and complex patients, that can easily build in a 21 or 30-day delay to their process if they had simply just been referred to a hospital-based provider to begin with. It's also important to recognize that when you're sending someone to have a procedure outside of a hospital, which may be more timely, there's less people in an OHP. So body mass index is huge. That's number one there. People have a BMI over 40. It's not just the incidence of respiratory episodes and the virtual certainty of sleep apnea. That's a problem. But if you have someone with a difficult airway or who's rolling over in a hospital, you can get 10 persons to that person's bedside, in a few seconds. In an OHP, there's a limited number of staff, and we don't physically have the people to move and take care of, to lift up 400-pound patients that are, on their back with an obstructed airway. It's something to consider. Along the issue of airway, anybody with significant COPD or pneumonias in the last 12 months when they're admission to hospital probably has a precarious pulmonary situation that is best done in a hospital because of the various number of different ways they will have to have an airway. An OHP will have 3 or 4 different ways of getting an airway. A hospital will have 10. If your patient has ever had congestive failure, ever, even if they were presenting an atrial fibrillation and now they're out of atrial fibrillation and they're great and they're a cyclist and they're very active, if they've had congestive failure ever, they should not have scope in an OHP. The fluid and electrolyte balances that occur with even a routine bowel prep, particularly the low volume bowel preps, which are osmotically based, can really, really screw up things. So congestive heart failure patients should always go to the hospital. Obviously, I think anybody who has unstable angina, who has chest pain requiring nitro, it's not necessarily that they're at high risk for a cardiac event. The real world kind of average, this happens all the time thing is they might wake up and complain of chest heaviness or shortness of breath. And in that patient, you can't send them home until they've been checked out at a hospital with a CK and a EKG and everything else. And that means your patient's going to the emergency room for 12 hours and the OHP has an adverse event and everything else that need, paperwork follow-up. So angina, symptomatic angina and nitroglycerin. And the last thing, again, goes to the limited number of staff that are typically in OHPs. If your patients aren't going to be able to independently dress and undress, get on and off a stretcher, or, particularly after sedation. If you think that they might barely be able to do that, but you're not sure that they should be alone in a changing room after sedation, taking on and off their clothes, that's another reason to consider a hospital-based procedure. Next slide. Just to point out, I'm not exactly sure whether you'll find this useful or not, but the point of this was FIT is a good test. When people have a positive FIT, there's usually something there to find. The chance that we find any kind of polyp at all, whether it's a small tubular adenoma all the way up to a cancer, 70% of the time we will find something that needs to be found. 10 to 15% of the time we will find polyps that are not yet cancer, but by virtue of their microscopic appearance and characteristics are clearly walking down the road to eventually becoming a cancer. So 10 to 15% of the time with a FIT positive test, we're finding and hopefully averting a cancer. And the actual amount of cancer is 3 to 5%. And again, that's something that all endoscopists have as a quality metric. Every year we find out how many tests we've done, how many perforations we've had, how many bleeding, how many cancers we've found, etc. Next slide. We are going to circulate after this talk. We're going to circulate some bullet points, but these are the things that I really want everybody to come away with, which is that family history for colon cancer in 2025 in Ontario, family history is parents and siblings. That's it. And it's not polyps, it's colon cancer only. Everybody else would get FIT testing. If they have a family history, however, they are never going to be FIT people. They are colonoscopy people. The idea of a baseline colonoscopy or a once-in-a-lifetime colonoscopy has no statistical or database validity. It is absolutely fine, and you are doing your patients very good service by using FIT exclusively. In order to summarize all the people that shouldn't have FIT, you can go through that sort of multicolored slide that we talked about before, or you can just remember that anybody who has an appointment in the future, for a colonoscopy doesn't necessarily need a FIT. And in terms of when to order the tests, I've found it useful to conceptualize it as, a FIT test gets you 2 years down the road and a colonoscopy gets you 10 years down the road. And and it's only then that you need to sort of become current again or re-up. And with FIT testing, it's important to get the referral out of your offices as quickly as possible, but it's also important to get it to the right place. And we are trying to make it as easy as possible to smooth out these referral pipelines so that that for unstable patients you have or complex patients you have 2 or 3 options, and that for very healthy, stable patients you might have 10 options. And the last thing is just to remind everybody on the call that, patients can have colonoscopy or they can have FIT. It's a choice. Both are offered under OHIP in Ontario. But as in our role as custodians of the system, and in order to keep your endoscopy facility with its maximum QBP budget and its maximum ability to serve your patients in other ways, it's helpful not to have large volumes of average risk colonoscopy. I think that's the last one, is it? Yeah, so I'm happy to take any questions at this point.
Thank you so much. We have a few just in our chat here. I'm just scrolling through. So there's some questions about the H45. So thanks for addressing that. Is FIT less accurate than colonoscopy for screening average risk 50? So I think you addressed that as well.
Yeah, I would say if you go to the studies, the one that I referred to, which we can put in the notes, which is Quintero, you'll find that, again, in terms of colon cancer mortality, in average risk people, they are statistically identical. The difference is that colonoscopy will detect greater amounts of advanced adenomas, ones that are greater than 1 centimeter. But again, the number of people that died of advanced adenomas is 0. And will always be 0. People only die of colon cancer. Our target metric is colon cancer mortality, and in that metric, they're absolutely identical.
If someone was found to have polyps on the colonoscopy, what is the guideline for FIT or a follow-up colonoscopy? I believe you touched on that, but I don't know if you have anything to add.
Yeah, so hyperplastic polyps, which you may sometimes see on a pathology report, they have no potential whatsoever to become a colon cancer. They are essentially normal lining. Like if I looked over someone's skin for melanomas or other skin cancers, I could find a whole bunch of bumps and abnormalities, some of which would be squamous or basal cells or melanomas, but I might find warts, I might find moles. And when I send those off to pathology under the microscope, they'll tell me that's made of wart, that's made of mole, that's made of cancer. But sometimes I will find a little skin tag. And if I send that off as a lump, then they would go like, hey, why are you sending this? This is normal skin. That's what a hyperplastic polyp is. They will never become cancer. They require no follow-up whatsoever. Hyperplastic polyps equals normal colonoscopy. Polyps that have an adenoma is the family of polyp, and there's tubular and villus and everything else. That when there's a recommendation made, it's not subjective, it's based on guidelines. So typically, a 10-year person who has a 10-year cycle will have a 5-year follow-up if they have only 1 or 2 polyps, if they're all tubular adenomas, and they're all less than 1 centimeter. If any of those are untrue, it's typically a 3-year follow-up. So there are established guidelines, but hyperplastic polyps don't require it. Typically, polyps are followed up with colonoscopy. The only time that you might want to switch over to FIT is, and I hesitate to use this after everything that we just said, is as a second best test. If your patient is just, for whatever reason, there are other health issues going on that make it less ideal for them. They have other more important health issues on the horizon, and screening needs to be addressed, but maybe the cost of deep sedation and bowel clean out electrolyte wise and fluid balance wise is a little more aggressive than necessary. And there is some validation for following up with FIT, but only for tubular adenoma only, less than 1 centimeter, 1 polyp only. But those people you can substitute for FIT. Generally, polyps, I think it's safe to assume they should probably have a colonoscopy.
Through all the questions, so I'll do my best to kind of theme these. There was a question in a couple of agreements of what is the average perforation rate for colonoscopies in our region, and I know I've been expecting to have that at your fingertips. So in the background,
actually,
oh, do you? Okay.
Yeah, so that's one of the things that we look at for every provider and every facility. It's typically quoted at 1 in 2,000, and practically, it doesn't really matter whether people quote it at 1 in 1,000 or 1 in 3,000. The issue is that this is not a level of negligence that we tolerate within the profession. It means that the very best endoscopist in the world at the peak of his or her powers is just going to have that happen 1 in a couple of thousand patients. So if your rate of perforation is 1 in 10,000, you're not amazing, you're just lucky. If your rate of perforation is 1 in 300, I think we need to sit down and have a talk. But I think you can safely say that it's a very, very unlikely complication. And I always stress to patients that, you know, the purpose of our interaction isn't for someone to get the scope to the terminal ileum heroically at any and all cost. Like many times, people will terminate the procedure because to proceed any further or more aggressively increases the risk dramatically. So, and that's where you see the incomplete colonoscopies. It's someone saying this is too dangerous to proceed. So in terms of danger, the perforation rate is probably needs to be looked at it also with the cecal intubation rate.
Thanks. I think we have time for one more question. What if a patient who had a normal FIT presents with symptoms before the 2 years and a colonoscopy being ordered is warranted?
Absolutely. If they have symptoms, colonoscopy is warranted. And if that colonoscopy turns out to be normal, they don't need FIT for 10 years. So they've had their colonoscopy, that gets them 10 years down the road.
Great. Thank you. Like I say, we have a couple of questions here we are not able to get to today, just being mindful of everyone's time. So we will follow up with a package and we'll include the answers to these questions. So our apologies if we weren't able to get to your question. Do you have any closing remarks, Dr. Kendall, before we log off?
No, I think it should be possible for us to communicate how to use the FIT like an expert in a simple way. So if it still remains complex and impenetrable, then I'd encourage you to follow up, and we can try and support that. And I'm more than happy to share my email address for people who want to have questions, and just send me an email and I'll respond to that.
Thanks so much. Thank you, everybody, for your time this morning. Have a wonderful day. We'll talk to you soon.
Thank you.